Jean-Pierre, thank you very much. So, risk scores for patients with non-valvular atrial fibrillation. And first of all, these are my disclosures. So let's provide some background and context. You've heard elegantly from John Cam about the risks and benefits that there are for patients with atrial fibrillation and different categories of risk. And we know that based on trial evidence and based on observational data, for patients with at least one risk factor, there's evidence within the guidelines. What do the observational data show us? They show us from the Garfield Registry that from 2010 to 2015, there's been a progressive increase in the use of some form of anticoagulation, from 57% to 71%. So it's gone up. So you might say, well, that's great. You know, we're following the guidelines. Are we? And one of the challenges is the balance between risk and benefit is poorly defined. So let's look a little bit more closely at the low and the high-risk patients and how they're managed in practice. And you've heard from John about how these are characterized and defined. In the left column, you will see that these are very low risk. These are CHADS-VASc of 0. This is CHADS-VASc of 1, and this is 2 or more. So nobody would dispute CHADS-VASc 0 being very low risk. But some interesting findings. Those with higher CHADS-VASc, clearly indicated by the evidence and the guidelines for anticoagulation, 28% are not anticoagulated in practice. Now we remember, in this important large program of Garfield, the decisions on treatment were based upon clinical judgment. They didn't require a risk score. And conversely, just over half very low risk patients, CHADS-VASc of 0, were anticoagulated. And John has just shown you the data to suggest that the net benefit is not there in this cohort. So what I suggest to you is that factors beyond current risk scores are influencing the clinical decisions to treat or not to treat. And this is serious. So my question is, can we do better than the existing risk scores in helping to predict events? And let's backtrack for a moment and look at the old CHADS-2 score, the ACCP score, and the CHADS-VASc score from 2009. And this is as evaluated in patients from the EuroHeart survey. I'm going to concentrate on the C statistics. And as you know, a C statistic of 0.5 is the play of chance. You won't do better than spinning a coin if you've got a C statistic of 0.5. So the ACCP and the CHADS-VASc did slightly better than CHADS-2. Let's look at the event rates. And indeed, as you apply these data to large cohorts like the Swedish National Patient Register, then you can see the events stack up as the score rises. This is ischemic stroke in yellow, it's unspecified stroke in light blue, pulmonary embolism, and then TIA. So there's no doubt that the events stack up as the score rises. But the low annual event rate in those with very low risks calls into question the use of anticoagulation in very low risk patients. So what we've done is set out to provide clinicians with a more accurate and user-friendly method of stratifying patients according to their risk of death. And our rationale is that clinicians are making a judgment, and if they've got a user-friendly tool that allows them to look at both stroke risk and bleeding risk all integrated, that may help. So the approach sounds complicated to start with, and we're indebted to an excellent collaboration with Karen Pieper, Joe Lucas, and others in Duke University. And this approach uses a machine learning approach to risk modeling. Why? Because it avoids some of the pitfalls of the old traditional multivariate type analysis, which made assumptions about sequence and then makes assumptions about relatedness. This new approach does not. It's based on nearly 39,000 patients, and the models were trained on indicators not just for one event, but for all three events. So for mortality, ischemic stroke thromboembolism, and for hemorrhagic stroke and major bleed within 1 year. And we compared the performance of the Garfield AF score with the CHADS-VASc score. Now, as you know, interpreting the C statistics is really in terms of the concordance, so-called C statistic, between predicted events and observed events. So here are true positives and false positives. These are the proportion of individuals with a predicted event who had an event and the converse. And the C statistic is represented by the area under the curve. So in this new score, this is very impressive. The C statistic for mortality is 0.78, substantially higher than we've seen in some previous studies. For stroke, for ischemic stroke and systemic embolism, 0.63. And for hemorrhagic stroke and major bleed, 0.67. This is better than has bled. And here I show you, this is for the comparison of Garfield AF with CHADS-VASc for the entire population. And for the entire population, you'll see the performance is better for all-cause mortality, 0.78 versus 0.66. It is similar for ischemic stroke and systemic embolism, 0.63, for the entire population. And for hemorrhagic stroke and major bleed, 0.67 versus 0.61. So what can we conclude from this? That the discriminatory capacity of the Garfield AF score was superior to CHADS-VASc. And later in this Congress, in fact on Monday, we're going to be presenting for the first time how this performs in low-risk patients, because that's in the hotline, because it's really a critically important question as to whether we can define those low-risk patients. The next steps, and these are already underway, is deriving a simplified score that can be web-based to make it easy, and then the entire score that is electronic, so it can lie within electronic data systems and automatically extract these scores to assist the clinician. Here's a web reference, and here is a screenshot of a patient that I've entered into the score. I've used a US patient, 89, with some heart failure, some renal dysfunction, and this blood pressure, and on antiplatelet therapy, and you can see this individual has a 20% risk of major bleeding in 1 year. And I think you or I would make a decision on treatment based upon considering those kinds of risks. So thank you very much.